Hello everyone, I am Supesh and I welcome you all to the first episode of Talktrig. Talks that will trigger, talks that will be intriguing. We have with us today our first guest, Dr. V Jatin. Dr. Vinay is an oncosurgeon and in today's episode, we'll discuss with him about his journey, his experiences, and ask him some questions about cancer. So, Dr. Vinay is someone who deals with cancer day in and day out. So, without further delay, here is Dr. Vinay Jatin.
Thank you.
Hello, Dr. Vinay. How are you?
I'm fine. Thank you for the invite, Supesh. And I extend a warm welcome to our viewers as well.
So, can you please tell us about your journey from MBBS to PG?
Well, it's been a long and arduous journey. After my 10 plus 2, I did my MBBS and then pursued post-graduation in surgery, general surgery from Sion Hospital in Mumbai.
Okay.
That was a 5.5 followed by 3-year course. Then I further pursued my super specialization in surgical oncology, which was another 3 years. Finally, I did a fellowship in thoracic oncology from Tata Memorial Center in Mumbai.
Okay.
And that's almost 13 years of studies, following which I have now joined as a consultant oncosurgeon at Bombay Hospital in Mumbai.
Wow. So, it's been a long journey and you're just getting started. We'd like to know what is a typical working day or working week for you like?
So my working days are spread between OPDs and operation theaters. So the days that I'm working in the OPD, I generally see patients around the clock. Dedicate around 30 minutes per new patient. I also have free OPDs in the afternoon from 2 to 4 at the hospital where I work. So generally wrap up by 6 and have a private OPD near my work, my home. So I'm there from 7 to 9 and generally wrap up my OPD days by 9. Operation theatre days depend on how long my case is. Some days I'm done by 6, some days by 10. And weekends are dedicated to academics. So on Saturdays, we have a case discussions, a journal club, and seminars with our residents. So since I'm also a faculty at the hospital for the DNB Surgical Oncology course. So this is how my week generally pans out.
Okay. So, it's a busy week for you.
Yes,
throughout.
definitely.
And you spoke something about free OPDs. So, this.
Yeah, so generally I work in a private hospital, but we do have patients coming from the lower strata of the society. So for those patients, we have something called a free OPD. We also treat these patients free of cost as well.
Oh. So, tumors, as I understand, are of two types.
Yeah.
Benign and malignant.
Yeah.
So, what is the actually the difference between the two?
So you're right. There are two types of tumors, benign and malignant. So the benign tumors are generally slow growing and they do not invade into surrounding tissues and they generally don't metastasize or spread to other tissues. Whereas malignant is the exact opposite. They tend to be a little aggressive. They invade other tissues and they spread to other organs and metastasize. Hence, they are a little more dangerous than benign tumors.
Okay. So, if you are talking about cancer, it is the malignant tumors which you are focusing.
So we focus on malignant tumors.
Okay. So, Dr. Vinay, which is the most common cancer in males and females?
So generally in India, we observe oral cancers are most common in males. Along with that, even lung cancers are very common in males.
Okay.
In females, we have breast cancer, which is more common in the urban areas. And we still have cervical cancer in the rural areas, which is more common.
And what is the molecular basis of cancer? So what is the underlying mechanism which leads to these cancerous changes?
So basically, it's an interplay between oncogenes and tumor suppressor genes. So in layman's language, oncogenes are, when they are mutated, it's like an accelerator being pressed in the car. And this promotes tumor formation. And you have tumor suppressor genes, which act as brakes. So when when they are not mutated, tumor suppressor genes prevent cancer formation. So that this cancer formation is an interplay between these
two
oncogenes and tumor suppressor.
So all these genes are normally present in the human body?
Yes, they are normally present in the human body. Mutations of these are what lead to cancer.
If you talk about the symptoms of cancer, like for example, bowel cancer, lung cancer, so what are the
So
symptoms?
in general, I'll give you an overview of what symptoms we generally tell patients to look out for.
Yes.
So non-healing ulcer in the oral cavity, in your mouth, on the tongue or in the gums for a long time, for greater than 2 weeks. So swelling in the neck, change in voice, difficulty in swallowing, and then a lump in the breast, bleeding from the nipple in females, bleeding from the vagina in females, which is not related to the menstrual cycle, postcoital bleeding. Then altered bowel habits is one symptom of bowel cancer. And you have non-healing ulcers on the feet. These can also lead to squamous cell carcinomas. So, and one of the symptoms that we commonly see is unexplained weight loss. So a lot of patients do come up with the unexplained weight loss. So in general, these are the symptoms that you generally tend to look out for.
Okay. Interesting to know. Any recent trends which you're observing, and what is the cause of this trend? And
So I would like to comment on two trends that we see. We're seeing a lot of younger patients being coming up with colorectal cancer. So we have a lot of patients in their 20s and the 30s who turn up with colorectal cancer. Also, we see a lot of women now turning up with lung cancer, partly attributed to the fact that there's the rise in smoking in these in females right now. And there's a bridging of the urban and rural divide. So earlier we used to see a lot of patients with breast cancer from the urban areas, but we are now seeing patients even from the rural areas turning up with these cancers. So these are the trends that we see nowadays.
So what are the stages of cancer?
So as we all know, generally cancer tends to have 4 stages. So the first 2 stages are what we call local disease, where the tumor is restricted to the site, the origin of the tumor. And the third stage is a locally advanced stage, where the tumor spreads to the lymph glands, the lymph nodes. So this is called locally advanced disease. And we have the last stage, which is stage 4, which is metastatic disease, where the cancer has spread from the site to another organ. So common sites of metastasis that we see are the liver, lungs, the brain, bone. These are sites where cancers generally tend to metastasize.
Okay. So something cancer which has originated in liver will metastasize to brain.
Yes, that is possible generally. So or a lung cancer can go to the brain or the bone, something like that.
Okay. There's something I read about the grades of cancer and some histopathological types.
So they denote the aggressiveness of the cancer. So you generally have 3 grades. They can be well differentiated, moderately differentiated, or poorly differentiated. The well differentiated cancers generally tend to do better than the poorly differentiated ones. Tend to be more aggressive. The poorly different. It's to do with the type of cells that are seen in pathology.
Okay. So depending on the pathology or the changes in that cell, that grade is defined.
Yes, how aggressive the tumor is.
And that then again determines the prognosis and how the treatment as well.
Yes, so the prognosis is determined by the grade.
Okay. And what are these precancerous lesions?
So precancerous lesions are lesions that tend to that have a potential to turn into frank cancer. So for example, you have leukoplakia, which is like a white patch in the oral cavity. Over a long time, these can turn into cancer. Or even you have, in women, you have pap smears which detect this precancerous lesions called CIN, cervical intraepithelial neoplasia. So these are detected on pap smear. So these have a tendency to turn into cancer. So if we catch these lesions at the right time, we can, halt its progression into cancer.
Okay. So we basically preventing it from becoming cancerous.
Yes.
Oh, that's good to know. What is the treatment approach based on the stage of cancer?
Generally, what we see is the first and second stage. Generally cancers are amenable to cure in the first and second stage, using a combination of surgery and or chemotherapy or radiation.
So this will be completely cured.
Generally. And the third stage is when you require some form of neoadjuvant. You need to give a therapy before the surgery to decrease the size of the tumor. It could be chemotherapy or surgery. It's just called as neoadjuvant treatment. And in the fourth stage, generally you have something called as palliative treatment, because it is not generally amenable to cure. So we could be chemotherapy, radiotherapy, or even supportive care that can be. So these are the main 3 pillars of cancer treatment: are surgery, chemotherapy, and radiotherapy.
What are the recent advances in diagnosis? Like, for example, some gene mutation or diagnostic kits are available like KRS mutation?
So, recent advances are in the radiological aspect as well as the pathological aspect. So,
Mm-hmm.
in pathological aspect, we have something called as next generation sequencing, where the entire mutational landscape of the tumor
Mm-hmm.
is presented to the physician, and then based on that, you can offer targeted therapy or chemotherapy based on those mutations.
Okay.
Another thing is something called as liquid biopsies, which are coming up quite a lot. So
Good
these are,
biopsies.
yes. So
Mm-hmm.
liquid biopsies are where your cell-free tumor DNA is detected in the blood, and that tells you that the patient has cancer. So these are the pathological trends. You have immunohistochemistry also coming up in a big way with a lot of staining to differentiate the various types of cancers that we have to confirm that this is that cancer. As
Mm-hmm.
well as far as radiological diagnosis is concerned, you have advances in mammography like 3D tomosynthesis. You have double contrast MRIs. You have a lot of molecular nuclear medicine markers in PET CT. So you have something for example, PSMA PET, which is prostate specific membrane antigen PET scan. So these
Mm-hmm.
are used in prostate cancers. They tell you where the location of the tumor wherever it's present in the body. So that is something that is coming up in a big way.
Yeah. So, Dr. Vinay, what are the investigations which are used to diagnose or confirm the cancer?
So, prime most, we require a biopsy to confirm the diagnosis of cancer. Almost all cancers require some form of biopsy. Apart from that, we require some form of imaging. So, to tell us this location of the disease and the extent of the disease. So, it could be in the
Okay.
form of ultrasound or CT scans and MRIs. And
No.
apart from that, you also require a PET scan to know the exact stage of the disease, how far the disease has progressed in the body. So, that is
Mm-hmm.
another imaging modality that we use for diagnosis of cancers.
What are the new treatment methods or therapies which are coming up in this oncology?
So each of the three pillars, surgical, radiation, and medical oncology, have some newer advances. So, for example, in surgical aspects, we see a lot of minimally access surgery being used in oncosurgery, as well as robotic surgeries, which are coming up in a big way. So,
Mm-hmm.
at one point of time, prostate cancer was done open, but nowadays it's very rare to see prostate cancer being
Cancer. Okay.
operated open. It's almost always done robotically. So,
Mm-hmm.
this is one of the advanced robotic surgery is coming up in a big way. Then in radiation, you have something called a stereotactic body radiotherapy, where a high dose of radiation is given to the tumor and to completely melt it. It is also used as a cyber knife in for brain tumors. So that is
Okay.
one uh, targeted form of radiation therapy. And in medical oncology, we have a lot of targeted therapy and immunotherapy coming up in a big way. So targeted therapy is where a specific mutation is targeted by molecules, and immunotherapy is using the body's own immunity for treating cancers,
So it boosts the body immunity to
body's
fight against
immunity, and
cancer.
it unmasks the cancer cells basically, so that they are
Okay. Okay.
targeted by the immune cells.
Okay. Okay. And also targeted radiotherapy. So that is focused on the
Yeah,
particularly.
particular tumor, and it's a high dose radiation that is
Okay.
quite precise and focused. So it's used in brain tumors, it is used in lung as well as in liver cancers.
Okay. Okay. Great to know. And so there are certain myths about cancer. We like to know more about them. Like, is cancer contagious?
No, generally cancer is not contagious. We get a lot of these questions from the caretakers actually,
Yes.
whether people living in the house, whether it's contagious. No, cancer is not contagious.
Okay. Okay. And can cell phones like the rising use of cell phones, can that lead to
So there is
cancer?
not much adequate data as such to tell us about this. There are a lot of long-term studies that are required still. Some studies have said that there is an increased risk, and some have said they are not. So we are still a bit, we need to take that data with a pinch of salt. We're not very sure whether they lead to cancer
Okay.
or not.
So we are hoping it doesn't.
Yeah,
Because
because
it's
it's widespread. The
it's
use is widespread, so you can't.
right, right,
Yeah.
right. And then there is another thing which comes up, that can this cancer surgery actually lead to spread, or the biopsy lead to the
So
spread
yeah,
of
that is
cancer? That is.
another this myth that we get very often, that biopsies tend to spread cancer, but that is
Hmm.
not true at all. It's just
Okay.
that the patient perceives that the tumor is there, because earlier they were
Right,
not aware that this tumor is there. So it's
right.
just a perception of the patient. It does not lead to more aggressive cancers or growth of the cancer at an uncontrolled rate. That is absolutely
Okay,
not
okay.
true.
And Does cancer always comes back, even if it is treated? Is it
So
been observed?
with cancer, there is a lot of unpredictability. So there's some cancers I would say are a lot more docile, and they tend to not recur. Like you have thyroid cancers or prostate cancers, which are amenable to wait and watch policies. But there are some cancers which are quite aggressive. Like for example, you take pancreatic cancer or brain tumors. They are quite aggressive and have a tendency to grow back. So yes, there are chances, but with adequate treatment and early diagnosis and treatment, the chances are quite minimal.
Okay, okay. So it doesn't happen
Yeah,
regularly.
it depends on the stage of the disease, basically. More advanced the stage, more the tendency for the cancer to come back.
And again, the grade that will
Yeah, more
determine how.
aggressive cancers then they tend to come back.
What are the carcinogens, and which of these are most commonly used in the modern society, in the modern world? Which are the ones we are regularly exposed to?
So you can say smoking is one of the most common things that we see quite often. Smoking and tobacco consumption. This is the most common cause of having getting cancers, oral cancers, lung cancers, and a lot of cancers. Apart from that, we have alcohol. You also have air pollution. You have ultraviolet radiation exposure to the sun as well, and some form of stress, inflammation in the body can also lead to cancer.
What are the risk factors for cancer?
As I mentioned, smoking and tobacco consumption in all its forms. You have alcohol, you have various dietary factors, you have pesticides and air pollution. Then apart from that, you have, as I said, UV radiation as well. These are some of the few risk factors that have been studied. Low fiber diet, red meat is known to be implicated in colorectal cancer. So these are the
Okay.
few risk factors that we see for cancer.
Okay, okay. So red meat and colon cancer, that is
That is a proven risk for colon cancer. And smoked meats, etc., salted foods are also a risk factor for stomach cancer.
Oh, okay.
So that
okay.
does play a huge role in bowel and stomach cancer.
Is there any precision medicine in oncology, like you talked about the targeted radiotherapy? So is there any other?
So precision medicine is basically a tailor-made approach for treatment to cancer based on the molecular characteristics of the tumor. So
depending on the patient, and which
it's
cancer
tailored
is-
to the patient and the
okay.
mutational burden that is seen on the next generation sequencing that we do. So according to that, you get targeted therapy. Now, what this does is it avoids unnecessary treatment to a patient where it's not going to benefit the patient doesn't get that treatment.
Right.
Hence, you avoid the expense as well as the side effects that go along with the treatment. So that is
Okay,
one
okay.
aspect
That is
that is
one
benefit.
advantage.
Yeah,
Okay,
that is
okay.
one advantage of precision medicine that we do.
I wanted to know about some new treatments which are emerging for cancer. Like there are some anti-cancer viruses which I heard about, some vaccines.
So these are all still in the experimental stage. We don't have a cancer vaccine as such. We have one in prostate cancer, which is called a Sipuleucel T, which is not very often used. So these are all still undergoing under experimentation and trials. So we don't have a cure-all vaccine or some sort of magic pill that we have for cancer. Not yet.
Okay.
Hopefully in the future.
Yeah. So there is no such guarantee that we have I have taken this vaccine, so now
you won't get the
immune
cancer
against
then.
this. Okay.
So, since you're talking about vaccines, there is one vaccine which you use for females, the HPV vaccine. That is, if given in between the ages of 11 to 26, that does bring down the burden of cervical cancer in females. So you have, but it's not a fail-safe guarantee. That's that's what I want to say. But it does help in reducing the burden of cancer. Cervical cancer.
Okay, got it. But it has to be taken in that age.
Yeah, before the female becomes sexually active and is exposed to the human papilloma virus.
Oh, okay. And there is something called gene editing which is coming up.
So gene splicing gene editing using the CRISPR technology. So as I said, this is also completely experimental and still undergoing trials. It's not this. We have something called as CAR T cell therapy also, which is like specialized cells of the immune system being used in certain blood cancers like leukemias and lymphomas. So that is something that has come up recently.
Okay. And then again there is immunotherapy which is coming about. And we hear a lot about immunotherapy.
So immunotherapy is basically using your body's immune system to kill off the tumor. So basically the cancer cells are masked by, they are not, the immune system is not able to recognize these cancer cells. So what immunotherapy does is basically unmasks these cancer cells so that your
Oh,
immune system can attack them and tackle off the tumor. At this stage, I would like to say that immunotherapy is quite an expensive form of therapy. But down the line, hopefully, as more and more immunotherapy is used, we will see the financial aspect of it being better, basically.
okay, okay. So, like the cancer cells hide in the within the normal cells, and the our immune system is not able to pick them up.
Recognize it because
Oh,
they
okay.
mask themselves,
Mask
basically.
themselves. And so again, these monoclonal antibodies, all these are also
So these are
type of.
basically for specific mutations that you have. So primos, you can say Herceptin is a
Mhm.
molecule that is used for breast cancer that has revolutionized the treatment of cancer. So when a breast cancer patient is HER2 positive, basically human epidermal growth factor positive, then we tend to use this molecule, and increased the lifespan of the patients wonderfully well. So
Okay.
this is just one example, Herceptin, which is trastuzumab. There are a
Mhm.
lot of other molecules as well, targeted therapy. You have bevacizumab, and you
Mhm.
have rituximab in Hodgkin's lymphoma, etc.
Okay. So you mentioned HER2. I heard this a lot. HER2, HER negative, HER
Yes.
positive. So what is this HER
So
actually, and
it's
what
a
is?
receptor on the breast cancer cells. So
Okay.
when it's generally when you have the HER2 is positive, you can use this molecule Herceptin, which it targets those cells only.
Okay.
And you have something called as hormone receptors also, estrogen receptor as well as progesterone receptor. So even when these are positive, you have some form of hormonal therapy that can be given to these patients. This is after your treatment is completed so that you
Mhm.
prevent recurrence,
Prevent recurrence.
prevent the disease from coming back. So these are
Okay. Okay.
forms of preventive therapy.
Okay. Okay.
So hormonal therapy is another thing that is being used in breast cancer very much.
Any other complications or sequelae about this cancer or malignancies which can come up, which you observe?
So we have something called obviously recurrences, and cancer surgery itself can be a big burden on the patient. So you have complications coming in from surgery as well, bleeding,
Mhm.
hemorrhage basically. And apart from that, sequelae as such, in the long term, it does have a lot of physical as well as psychological sequelae, I would say. So
Okay.
that is one aspect that you need to tackle.
Okay. Okay. Can stress lead to or impact cancer progression?
So it is shown that chronic psychological stress can lead to, an increased catecholamine production, more adrenaline, noradrenaline. So which in the long term tends to induce changes in the cells, and that can lead to cancer. So it has been proven that just chronic stress does lead to cancer.
Okay. Okay. So does it some oxidative cell damage
Yeah,
or
free
free
radicals
radicals?
generated and oxidative damage at the molecular level. There are a lot of changes that are induced by catecholamines that cause the cancer.
Okay. How can the treatment outcomes for malignancies be improved? Suppose a
So,
patient is undergoing cancer, so how
for
better?
prime most, I feel early diagnosis is the key to improving outcomes. So you have to, catch the cancer at the early stage, and that is how you will be able to provide better outcomes to patients.
Mhm.
Another thing is accessibility of treatment. And a
Mhm.
third thing is affordability of treatment. Cancer treatment is very expensive today. And the government sector, we have good hospitals, but they are not able to keep up with the burden of the cancer patients. So we need cancer care to be more accessible as well as affordable
Okay,
and catch
okay,
the disease early. That's prime most.
okay, okay. So the earlier the cancer is detected, the
Better the
better the
chances of
prognosis
cure
and
and
better.
survival. Yeah.
Okay, okay. And so, like you mentioned, there is a mental toll also which cancer takes on these patients and their
Yes.
families.
Yeah.
So, is there any counseling available for patients and their
Yes,
families?
in fact, we have specialized courses in psycho-oncology,
Oh,
so
okay.
especially at Tata Memorial. So these are dedicated psychologists or counselors for cancer patients. We see a lot of depression and anxiety disorders amongst this group. So yeah, definitely counseling is one aspect that helps in a big way.
Mhm.
And another thing about counseling that I would add over here is something called as genetic counseling. So it's not to do with the cancer diagnosis per se, but the risk that a patient has for cancer. So in familial cancers or hereditary cancers, you have something called as genetic counseling, which prepares the patient for, what is this chances of getting a cancer, what is the treatment plan like, if there any preventive treatment available to the patient. So these are the various factors that are detected in genetic counseling. This is some other form of counseling that is done for cancer patients.
Okay, great to know. Another thing which I wanted to ask is hair loss with chemotherapy and radiotherapy.
So yes, chemotherapy is known to induce hair loss, and it is reversible. And especially nowadays, you have newer molecules that come up, so you have a less of side effects. So, and plus there are newer techniques such as scalp cooling, which help in reducing the hair loss.
So this will be
Yeah, so there's a machine
Scalp.
which helps to cool the scalp. It's supposed to be beneficial for patients for hair loss.
Okay. And these are generally reversible once.
The hair loss is generally reversible.
Both with radio as well?
Yeah, radiotherapy, unless you give it locally to the scalp for the brain tumors, it generally doesn't induce hair loss. But chemotherapy, yes, it does.
Okay. Yeah. And I wanted to know about this something I heard like Tumor Lysis Syndrome. So what is it exactly?
So Tumor Lis Syndrome is more to do with hematological malignancies, blood cancers like leukemia and lymphoma, where the cells they release their they burst and they release their contents into the system, into the body. So disrupt the homeostatic balance of the body. So it manifests as metabolic abnormalities. So you have hyperkalemia, that is high potassium, hyperuricemia, that is more uric acid, then hypocalcemia, that is less of calcium, and more of phosphorus, hyperphosphatemia. So it is a true medical oncological emergency and needs to be managed in the ICU. So it is generally managed with intravenous hydration and drugs to lower the uric acid and manage all the electrolyte abnormalities. Generally seen in leukemias and lymphomas. Rarely you have solid tumors like neuroblastomas and hepatoblastomas also, which can lead. But solid tumors generally do not cause tumor lysis as much as
mostly in
blood cancers. Leukemias.
Okay. What is the cause of death in this terminal ill cancer patients? Is it some organ failure or?
So it's per se cancer-related deaths may be due to metastasis. So metastatic disease is what leads to organ failure. So in the liver, for example, it can lead to liver dysfunction and liver failure. In the lungs, if there are extensive meds, the patient may not be able to breathe and develop ARDS. And apart from that, there are other causes like chronic malnutrition can also lead to death. Septicemia, especially in patients receiving chemotherapy. So these are a few of the causes that can. Also, cancer is a prothrombotic state. That is, it promotes thrombosis. So you have a higher risk of getting myocardial infarction or heart attacks and stroke in these patients. Yeah. So that's what, these are the few causes of death in cancer patients.
Okay. And then is there any sudden unexpected deaths which you observed or any cause for that? Or
so spontaneous hemorrhages in cancers and renal cancers and brain cancers can lead to spontaneous death.
Okay. So the patient was ambulatory and then
and suddenly you have this a sudden hemorrhage can give rise to, because these tumors are quite vascular.
Okay. And then I wanted to ask about this something which has come up is second primary malignancy, and this is secondaries. So as I understand, secondaries are the metastasis from the primary tumor. And what is this second primary malignancy?
So second primary malignancy is having another malignancy in a patient who already has a malignancy. So this may be at the same time, which is called a synchronous, or it may occur after completion of treatment, a few months after completion of treatment of the primary cancer, which is called as metachronous malignancies. So you do see a lot of second primary malignancies. For example, in patients with oral cavity malignancy, you tend to see cancers in the food pipe as well as the lungs. So these are the second primaries in these patients. For example, survivors of osteosarcoma in childhood can have retinoblastomas, which are tumors in the eye. These are some of the known second primary malignancies. The risk of second primary malignancies always remains, especially when a patient in a childhood has received radiation therapy. So there are chances of in adulthood developing leukemia or lymphoma as well.
Oh,
So these
okay,
are
okay.
what second primary malignancies are, where you've already received treatment or have a cancer and you have
So the
these are
chances
different. Yeah,
increase. Okay, even though
generally,
it is a different cancer.
yeah, it's a different cancer. In the oral
Okay.
cavity, generally you do that. You see that because of something called as field cancerization. Now, tobacco induces changes right from the mouth to the food pipe to your airway. So this is like the entire environment is exposed to your toxins from tobacco, and that is why you see multiple concomitant tumors in these patients.
So, like this smoking and tobacco, I guess these are the most
Yeah, the
common and this
most villainous,
dangerous.
yeah, villain. They are the villains in causing cancer in
Oh,
population.
okay, okay. There are some increased anemia or increased risk of infections or increased thrombosis in cancer patients. So, does that generally happen?
Yeah, that's because of the suppression of the immune system, the suppression of the bone marrow as well. Especially patients who are on chemotherapy, they always tend to have decreased WBCs as well as decreased RBCs.
So, these are
So
side effects of chemotherapy which are
chemotherapy. This is
kicking in.
very common side effect of chemotherapy. Bone marrow suppression, which leads to decreased RBCs, anemia, and increased risk of infections, as well as platelets, drop in platelets.
Okay, okay. So, there are some drugs which increase to this
Yes,
blood
we
counts.
have. Fortunately, nowadays we have, colony stimulating factors GCSF and GMCSF, granulocyte colony stimulating factors, as well
So,
as
this stimulate the bone marrow.
yes, they stimulate the cells in the bone marrow to produce more WBCs. So generally, patients are given these injections to increase their WBCs post treatment, post chemotherapy, so that
Okay,
they're
okay.
ready for the next cycle.
Okay, prepare the
Yeah,
patient
prepare
for
the
the.
patient for the next cycle.
Okay, okay. And even the infection chances,
Yes, they are
that will
reduced.
reduce.
Yeah.
Oh, so, that is a useful part for a
Yeah,
cancer.
so continuing treatment in cancer. Yeah.
Mhm. Can you tell us about a complex case or a surgery you had in the
So
past?
I do get a lot of complex cases. Our institute being a tertiary referral institute. So
Mm-hmm.
I remember last January we had a patient who had a huge tumor in the left side of the abdomen going up to the chest. So this was something called as a chondrosarcoma, a tumor developing
Chondrosarcoma.
from the cartilage of the rib. So it was involving his anterior abdominal wall, his spleen. It was going up into the pushing the diaphragm. That's the muscle that separates the thorax and abdomen, and going into the thoracic cavity. Now, this
Okay.
patient required a lot of careful planning with my team, as well as a plastic surgeon being involved.
Mm-hmm.
So after 8 hour long surgery, I managed to remove the tumor. It was 25 centimeters long, weighing
Oh,
7 kilograms. So the patient
oh my God.
instantly became lighter by 7 kilograms.
Oh my God.
The plastic surgeon had to do a lot of reconstruction as well, reconstruct his abdominal wall, the diaphragm. So this was just part of the treatment. I realized after that, the patient, because of this humongous surgery,
Mm-hmm.
developed acute kidney failure. So
Oh,
then he
okay.
was somehow managed intensively by our nephrologist as well. And we
Mm.
managed to send the patient home on the 18th day after surgery.
Okay, okay.
Hale and hearty, walking,
Oh,
talking,
great.
and eating. It's been 1 year now, and the patient is absolutely healthy.
Okay. But how did it grow to so much?
So the patient was, first of all, anxiety about treatment. He was
Mm-hmm.
scared. He had already been operated by a surgeon where the surgeon only took a part of the tumor, a biopsy of the tumor, and said, "You've been cured."
Oh,
And so he had lost his faith in doctors, as well as he
oh
was
my God.
very scared of the treatment.
Okay,
So
okay.
that is why he just, it was there for almost 12 months.
Not a trauma he must have been going through, and
Yeah,
to know that it's again still there.
still there.
Oh
He
my
was
God.
not
He
told
was
that it was still there, and
he
that is why,
it.
yeah. So that is why he was reluctant to take treatment. His daughter-in-law somehow convinced him, and
Oh my God. That's really
yeah, that's one of
strange.
the
Okay.
complex cases that I had.
And does everybody need to take a second opinion from
So
other
it's a
doctors?
very personal choice. So I would say taking a second opinion, everyone can. But when there's a dilemma in treatment, or when a treatment offered to you is too radical, or when the chemotherapy offered to you is too toxic, and you feel that there may be alternatives available, or
Mhm.
when you've lost all hope, you have stage 4 cancer, and there's nothing else available, definitely a second opinion is warranted. You can this. But the other aspect of this is there shouldn't be too many second opinions being taken.
Right.
Something called as window shopping that is being done.
Okay.
So the patient goes to multiple doctors and finally doesn't end up taking any treatment and opts for alternative medicine.
And again, it delays.
It delays treatment, and the tumor which is operable or curable may become inoperable and incurable. So that is one thing.
Time is very critical in this.
Exactly.
So, what do you think are the essential attributes or qualities for an oncosurgeon?
So passion is prime most, I feel. Passion.
Because you are dealing in patients with cancer day in, day out.
Passion has to be there. Compassion, innovation. Then you have to have empathy for the patients. Then you need good communication skills, adaptability. And as a surgeon, you need dexterity as well. Dexterity and adaptability are prime most when you're a surgeon. So these are a few of the attributes that you require. And obviously teamwork, being a member of the team is what team building and teamwork is. These are few of the attributes that an oncosurgeon needs.
What is your motivation? What keeps you going?
So there is a motivational quote that I, follow. I mean, it's something as live for self, you'll live in vain. Live for others, you live again. So that is what I think keeps me driving. The need to do.
That is really profound.
Thank you.
And any message you would like to give to our viewers or listeners?
So as far as cancer is concerned, it's mainly the cancer primarily I feel is because of bad luck. So how you can prevent chances of getting cancer is by following a healthy lifestyle. Have your balanced diet, consume with a lot of fruits and vegetables, avoid alcohol, abstain from smoking and tobacco. Even being overweight is problematic. Obesity is also a risk factor for cancer. So avoid additional weight gain. Consume more fruits and legumes. Avoid red meat. Apart from that, daily physical exercise, engaging in some form of physical exercise is most important. And basically just live a balanced lifestyle. That's
so the more active you are, the less the chances.
Less chances of. These are basically a few of the points that I would like to share with the viewers.
Yeah. Okay. Because we hear this too often, and even our family and friends keep on telling this, but now an oncosurgeon is telling you, please be active, please be engaged in some kind of physical activity on a daily basis.
And if you have symptoms, please approach a doctor, get yourself screened. That is most important.
Yeah, that happens that patient is afraid or sometimes it's just ignorant that it's just
that is also an issue. Yeah.
Okay. So Dr. Vinay, it was great talking to you and listening to your insights. Thank you so much.
Thank you for the invite once again. It was really great sharing my insights about my journey and my experience in cancer. Thank you.
Thank you. So, ladies and gentlemen, this was Dr. Vinay, and I hope you enjoyed listening to him as much as I did. If you liked the episode, please do like and subscribe to my channel, Talktrig, Talks That Trigger, because I will be bringing to you more such intriguing conversations. Thank you for watching.